Thanks again for having me today. It's been a great pleasure, and I'm very happy to speak to you again. At my earlier talk, there was a good question from Dr. Al-Mohammadi about how to triage requests for next-generation sequencing, i.e., how do you determine when to do the molecular tests that have been requested? How do you avoid the unnecessary tests? So that theme of lab stewardship is what brings me to present this talk to you today. And the lab testing that I focused on in particular were JAK2, V617F, and BCR-ABL molecular testing. So I'll go through these two genetic abnormalities a bit in terms of hematologic disease, and also how we can find them in unaffected individuals. And then I'll go through the experience I had developing the CBC-based thresholds for basically automatically triaging these particular molecular tests. But I'll pause there for a sec to introduce a program that we have at our medical school. Are there any medical students here today? No medical students? Oh, it's okay. So in our medical school, we have what's called RIM, Research in Medicine. And it's a new longitudinal program that pairs medical students in their first year with the research mentor. And they carry out a research project throughout their first 3 years of medical school, and they're expected to culminate in their fourth year with some final product. It could be, usually it's a paper, but it could be a poster, some kind of educational material, an app for a smartphone, some kind of policy. And it introduces our students to research and really teaches them the foundations, the fundamentals of doing proper research in medicine. And all the data I'm going to show you today are from a project I developed with a first-year medical student. She did all the work. So when we see the outcome and the changes that happened, I want you to keep in mind it's from a first-year medical student's work. So I'm just going to start quickly with some thoughts on representative cases. So in each of these scenarios, we get a request for JAK2 or BCR-ABL testing. This first one, 61-year-old, white blood count is 8. It comes in as a peripheral blood. This is the only information we have. Would anybody say, yeah, great idea, do those tests? What about this one? Patient's a little bit older, white count is 2. Sounds kind of silly, doesn't it? But we get these all the time. Last one. White blood count's higher, patient's younger, same molecular tests are requested. Would you do JAK2 or BCR-ABL on this person? Yeah? What about now? Absolute lymphocyte count is 9. So, yeah, should send it to a different lab. So, I mean, everybody in this room understands why this is somewhat funny. But if you're the person ordering these tests, it may be that you're a family doctor and you have to know everything about everybody, and it's hard to keep up with all the molecular tests and the nuances of what you need to order to work up what and how to get a patient ready to be properly referred to the right specialist. And we're so strapped for resources and we're so short on family doctors, often they'll just order whatever they can and hope something was right. But that doesn't help us who are looking after the lab's resources and who have to go through all these tests and take the time to report them. So just briefly, the tests we're talking about will be RT-PCR-based tests for BCR-ABL, and BCR-ABL is the gene fusion that happens when a Philadelphia chromosome is formed. And the Philadelphia chromosome was so named because it was discovered over 60 years ago in Philadelphia by this PhD student, David Hungerford, when he and his supervisor were screening leukemia cells for identifiable karyotypic abnormalities. And this one kept popping up in CML. This was the first time a genetic defect was linked with a specific human cancer. And then, of course, JAK2 is the other one. When I was in grad school, we said JAK stood for just another kinase, because JAK2 was identified by high-throughput PCR-based studies, and they found all kinds of kinases. This was just another kinase, we thought at the time. But of course, JAK refers to Janus kinase from mythology, and Janus was this two-headed person in mythology, and this reflects the fact that there are two almost identical kinase domains on the JAK2 molecule. I personally think that my twin boys are a good kind of double-faced representation, so maybe this could be called twin kinase. The other thing we get from the name Janus, who is, among other things, Roman god of beginnings, is the word January. That's where January comes from, Janus. So BCR-ABL in hematologic disease, I don't think any of this is news to folks in the room. This is, of course, a required abnormality to diagnose CML, but also we see it in a portion of B-ALL cases, especially in adult cases, and then a small fraction of AML cases and MPAL cases. JAK2, on the other hand, we see in polycythemia vera, essential thrombocythemia, primary myelofibrosis. For PV, the main point here is you can get the exon 12 mutation, which I'm not speaking about today, but for my purposes, and fortunately for my project, the V617F mutation accounts for more than 95% of JAK2 abnormalities in polycythemia vera. Now, for the other MPNs listed here, it's important to note that roughly half of them will be positive for JAK2 V617F. Roughly a third, the ones that are negative for JAK2, will have a CALR mutation. And then what's left, about a sixth, there's a split between MPL and then being triple negative. And triple negative probably means they're just positive for something we haven't found yet. We'll also come across JAK2 in our WHO under the section for myelodysplastic myeloproliferative neoplasms with ring sideroblasts, which we heard this morning will be called something else in the future, but more than half of those cases have the V617F JAK mutation. And then lastly, what I don't want you to think about is the so-called JAK2 rearrangements like PMC1 that are associated with myeloid and lymphoid neoplasms with increased blasts. So we're really talking about V617F, and this really limits us to myeloproliferative neoplasms. So that's in hematologic disease. I do want to highlight that you can get the JAK2 mutation without having other features of hematologic disease. This is a study from Copenhagen a number of years ago, and they looked at 600 or 700 patients from the healthy population, and 0.1%, so 1 in 1,000, had a JAK2 mutation. And if you'll look down here, the allele burden was roughly 5%, almost 5% in the two groups. And the two groups that they identified in the end were the group that went on to develop a mutation, and these were overall the patients who started with a higher variant allele frequency and ended up increasing that amount. But not dissimilar at the beginning of the study were the patients who didn't go on to develop an MPN, and they still had certainly greater than 1%, several percent, up to 5% abnormal JAK2. Did not go on to have disease. So I think that's important to keep in mind. The other is, a little less well known, is BCR-ABL fusion transcripts are also detectable in healthy individuals. This particular study, they did not report the abundance of mutation. They do, however, cite the sensitivity of their assay, which tells us that we have at least a 1 in a million cells are being positive here, but they found the P210 isoform of BCR-ABL in 10% of healthy individuals, 1 in 10. Okay. So with that in mind, I became involved in the molecular lab around 2010. So in 2010, we developed a new position called the section head for molecular hematopathology, and I was asked to take that position up, which I was happy to do, and it quickly became very busy, because as you'll see, from 2020 to 2021, our test volume went up by more than 30%. It was an astronomical increase for us compared to the previous 5 years that showed a relatively gradual, though positive, growth. So where did all this come from, and how is this possible? We're not seeing that many more patients, certainly. Our population is relatively stable. And we weren't doing that many more marrows either, so something didn't add up. So I thought about how can I address this, and then how can I make this a good project for a student. So I ended up looking at all of the tests we offer, and I thought the ones that made the most sense and might be the most logical to track are BCR-ABL1 and JAK2. And this goes back to the fact that they're associated with myeloproliferative neoplasms. And in the diagnostic criteria for these, we talk about cell counts, okay? And they are uniformly high cell counts. They're proliferative. So we can see that just like the total test volumes, JAK2 in the orange bars also increased over the years, and there was a particularly big jump from 2020 to 2021. JAK2, on the other hand, was quite stable over the years, but also big jump from 2020 to 2021. So we identified this as an excellent reason to look for an opportunity to intervene and identify what we predicted to be unnecessary testing. So if we go back to those representative cases, we all appropriately chuckled at this screen, so I appreciate that participation. This is the kind of stuff that we would find looking at a bone marrow report or some other reason to look into a patient's history and just kind of digging through the previous tests that were done, and for reasons that just weren't obvious. Why was JAK2 or BCR-ABL being done on a patient with a normal white count? Or someone who had cytoses? It made no sense. So we thought some guidance, either for the people ordering the tests or some rules that could be applied in the molecular lab, could help this problem. So the basic structure of the study was to take a 6-month snapshot in time, and that went from November 1st, 2020 to April 30th, 2021. And we pulled all of the requests for JAK2 and BCR-ABL testing from that time. And what we were interested in is patients who didn't already have some known diagnosis. We certainly didn't want any CML patients who were being monitored with BCR-ABL1 levels. So we eliminated anybody who already had some known diagnosis. That wasn't the population of interest. We also had to eliminate patients whose samples didn't come with associated CBC values. So we get specimens from multiple provinces, and our laboratory information systems don't talk to each other. And although our molecular techs are supposed to do so, they don't always get the opportunity to call and request CBCs. So those patients were also excluded. Now what we were left with was basically previously undiagnosed patients who were getting JAK2 or BCR-ABL1 tests, and they fortunately came with CBC values at the time those tests were ordered. We thought, well, what are we going to do? How do we judge whether or not these tests are appropriate? We need some kind of a framework to base our decision-making on. So we went back through the WHO criteria, and we took the cell counts that appeared from the MPN chapter. So white blood cells greater than or equal to 11. This is the minor criterion from PMF. Hemoglobin greater than 160. This is the female, the lower hemoglobin cutoff for a polycythemia vera diagnosis. And of course, the one we do a good job with, because the criteria haven't changed, is the platelet count of greater than or equal to 450 from the diagnostic criteria for essential thrombocythemia. And while there is no stated required white blood cell count in the 4th edition revised WHO criteria, and the 5th edition says you need leukocytosis but doesn't define it, the 4th edition does say that a count of 12 or more is the typical presentation. So we thought, that's better than nothing. Let's use that number as a cutoff for BCR-ABL testing. So with that framework, we then went back through and looked at all of the tests that were done during that 6-month period of time. So that number is shown here. So 316 BCR-ABL, 418 JAK2 tests. And what my student did is she applied the different permutations of those criteria. So either applying the white blood cell count requirement alone, or hemoglobin requirement alone, or platelets alone, or combinations of 2 or combinations of 3. And what she ended up finding was that unless we let any one criterion satisfy the lab, we would actually eliminate way too many tests. So the final set of thresholds we decided on was, for BCR-ABL1, you just needed to have a white count of 12 or more. And for JAK2, you just needed to have a white count of 11, or a platelet count of 450, or hemoglobin of 160. And when we applied those, our test volumes, theoretically, went from 316 BCR-ABL tests down to 20. Went from 316 down to 92. Importantly, the number of positives that we would have tested didn't change. We wouldn't miss anybody. That was huge for us. Same principle applied here. For JAK2, we had tested 418 in that time period. Had we applied our criteria, we could cut that by 27%. 73 positives when we tested everybody, and we would have missed 4 positives with those criteria. But what we found was the 4 people who had positive JAK2 testing, 3 of them had no further up testing ever. They didn't die. They didn't have a bone marrow. There was no other molecular. So we presumed from our limited ability to search our LIS that there was no reason to further pursue or refer that patient. So maybe this was something that got checked off by accident. Maybe these were some of these normals that just happened to have the molecular. And maybe they're on their way to developing something. But at the time, no reason to do further workup. And the last one had MDS NPNU. And we all know that wasn't diagnosed from peripheral blood alone. They went on and had a bone marrow, which in my opinion is the correct specimen to use to do these molecular tests, not peripheral blood. So we extrapolated these numbers. So basically doubling our test volume from before. So if our volumes were 316 and 418 in a 6-month period, we double that. This is what we would predict that same cohort would represent in a year. And then this is how much we could reduce it to if we used our thresholds. That would be 448 fewer tests for BCR-ABL, 226 fewer tests for JAK2. And if we look at these tests the cost per test, and BCR-ABL being the much more expensive, almost $300, and JAK2 is $64, we get an absolute savings of $144,000 just by implementing some CBC-based automated thresholds to automatically triage out unnecessary tests. So we developed a memo, and we put a memo out in February of this year, and it basically explained that on April, I think the 4th was a Monday, we will be implementing this triage process. And unless you have at least one of these 3 criteria, you won't get a JAK2 test. And unless you have a white count of 12 or more, you won't get a BCR-ABL test. And we vetted all this with our clinical hematology colleagues as well, and they agreed. In fact, they said you should have those counts for at least a month. So we added that in as well. Unfortunately, they put my phone number on the memo. So this message went to Newfoundland, PEI, New Brunswick, and all of Nova Scotia. So a catchment of a little better than probably 2.5 million or so. I got 1 phone call. I only got 1 phone call. It was from an internist who works in the community, and he said, but JAK2 is described as an independent risk factor for thrombosis, especially in weird spots. I'm going to need that. I said, then you'll get it. Just call us. We will cancel it automatically, but there will be a line that says, give us a call, and we'll do it if you really need it, because it's not based on CBC. It's based on something else, and we allow for that. We can't unilaterally eliminate everything based on CBC. So I don't have the breakdown of BCR-ABL and JAK2, but I did, just before I left home, get my lab techs to check. And since we've implemented the memo, 40% fewer total BCR-ABL and JAK2 tests have been done. So we predicted, I think back here, so we predicted a volume reduction of 46%. And what we're seeing so far in the first 6 months is 40%. So pretty close, pretty good. And only once have we had hematology not like this process. And they had a case of a patient with splenomegaly NYD, and they didn't have high counts. They said, well, we need JAK2 so we can talk to our patient about it. And I said, sure, but what are you going to tell them? They don't have JAK2 and a disease that you can diagnose without a bone marrow. And they said, sure, but we'd like to have it anyway. And I said, but half of the time JAK2 is going to be negative if it's an MPN. And they said, sure, but half the time it's going to be positive. I said, okay, let's flip the coin. So we did the test, and it was negative, and they went on to have a bone marrow anyway, just like I said. But this was 1 out of hundreds. It's a drop in the bucket. So for us, this is still a win. And I did want to point out, if anybody really noticed, and I don't blame you if you didn't, but in 2021, our BCR-ABL test number was a little over 1,600. And we predicted that we would be 600 per year. I just want to remind everyone where these numbers came from. This number came from us excluding everyone who had CML and was getting many follow-up BCR-ABLs, or anyone who had ALL and got BCR-ABL testing. Those still happened. So we are only triaging and influencing the number of tests done on new patients. So it's actually it's a cohort of everyone who gets testing done. So the fact that we're seeing a 40% reduction in overall tests for CBC thresholds that really only apply to a minority of the populace that we serve, I think is really quite impressive. So I will wrap up there, and I just want to highlight a couple of things. First, I think, as has been made very evident from the talks today, hematologic disease will continue to be based more and more on molecular testing. And that means the need for molecular testing will continue to increase. And I can tell you that just in the last year, we've had to hire a second molecular genetic analyst. We created a genomic analyst position, so we now have a dedicated tech who looks up all of our NGS and starts the preliminary analysis and lit review for all of the variants we get. We just can't keep up with the volume like we did before 2020. So unless manpower and lab resources keep pace, what else could we possibly do but try to reduce the number of unnecessary tests that are coming into the lab? And fortunately, so far, and perhaps it's only going to be BCR-ABL and JAK2 that are this easy, but CBC-based thresholds are logical and they are easy to implement. It's an effective method to reduce unnecessary molecular testing, and by all means, I do believe that the rest of our molecular test menu needs to get a close second look, because further auditing is warranted, and we may be able to identify additional opportunities to improve the way our molecular lab works. So with that, I certainly have to acknowledge the hardworking lab techs in the QE2 Health Sciences and Molecular Diagnostics Laboratory who helped us gather the lab data, and Alex Eaton. So she is just going into third year now at this point, so she'll be graduating from med school in 2 years. Hopefully I can snag her for pathology, but who knows. Anyway, it was her hard work that went into creating these thresholds, and she has literally saved us probably over $150,000 this year. Happy to answer questions when we get to the panel section, and I do appreciate your attention. Thank you very much.